clearer that this is a benign lesion as it appears as a well-defined lytic lesion, which could be mildly expansile with a sclerotic margin. Here is a case of a 12-year-old male presenting with scalp swelling, and on the lateral skull radiograph, you can see eosinophilic granuloma appearing as a lucent lesion with a characteristic beveled edge or the hole-in-hole appearance. This is because of the unequal involvement of the inner and outer tables of the calvarium. If there are multiple skull lesions, they can coalesce, and this would give a geographic appearance. Here we can also see that there is a mandibular involvement, which may lead to a floating tooth appearance due to destruction of the underlying alveolar bone. Here are CT images, an axial CT bone window, and 3D reconstruction. And here we can better appreciate the more extensive involvement of the outer table of the calvarium, which leads to the beveled edge appearance. Keep in mind that for lytic skull lesions, there are other differentials which we can remember with the acronym TROMEL. These include tuberculosis, radiation, osteomyelitis, multiple myeloma, metastasis, epidermoid, and lymphoma or LCH, which is what we discussed earlier. This is in contrast to bone lesions in other parts of the body where we consider these differentials with the mnemonic phlegnomachic. And note that eosinophilic granuloma is also included in the differentials for these lesions, because these can also present in other parts of the body, as in this case, where this is a patient with LCH with spinal involvement. We can see in the lateral radiograph severe decrease in height of T6 and T11 and T12, and this is the so-called vertebra plana deformity, and this can lead to back pain or sometimes scoliosis as well. CT imaging can be done to better demonstrate bony anatomy and involvement, particularly at the skull base, and this can also be done to assess for extension into the dura or brain parenchyma. MRI, of course, is better for marrow and soft tissue definition. It would appear hypointense on T1, hyperintense on T2, and these lesions typically enhanced with gadolinium contrast. In the evaluation of these patients, it's important to assess for disseminated disease, and this can be done through bone scintigraphy, skeletal survey, full body MRI, as well as FDG PET. Treatment for these patients is usually just asymptomatic, and you can just follow up these patients until their spontaneous involution. However, for cases that are large or symptomatic, we can do curettage, ablative techniques, and direct intralesional methylprednisolone injection. This is for the localized disease. However, if the disease becomes disseminated, you would have to give systemic steroids as well as chemotherapy. Moving on to the malignant diseases, osteosarcoma is the most common primary malignant bone tumor in children and young adults. There's a slight male predominance, and we can see the peak incidence at 15 to 25 years. It has a bimodal distribution, and we can see that in the elderly population, the incidence rises again. It presents as pain, swelling, and mass, similar to the other lesions we've discussed, which can make it difficult to diagnose clinically. There are many different classifications, but the most important to know would be the intramedullary high-grade osteosarcoma, which is also known as conventional osteosarcoma, because this compromises already around 75% of the cases that you'll see. While it's uncommon, it's also worth noting telangiectatic type of osteosarcoma, because it can mimic an aneurysmal bone cyst on radiographs, and we don't want to miss a potential malignancy. So if there's a high clinical suspicion, we can order CT and MRI to distinguish between telangiectatic osteosarcoma and aneurysmal bone cyst. For conventional osteosarcoma, it usually arises from the medullary cavity of the metaphysis of long bones. Most commonly, this is seen in the distal femur and proximal tibia. Here is a 17-year-old male presenting with knee pain. So, given the location of the tumor, usually we would see this as a typical case, an adolescent with knee pain. And this can lead us to missing the diagnosis because we usually don't think of malignancy in otherwise healthy teenagers. So, this emphasizes the importance of imaging in these patients. So, in these AP and lateral knee radiographs, we can see that there's a sclerotic lesion in the distal femoral metaphysis. And on lateral view, we can better appreciate the spiculated periosteal reaction in a sunburst pattern. And we can also see there's a raised periosteum, resulting in the classic Codman triangle. It's worth noting not all osteosarcomas will present in this classic manner. Some can have varying degrees of mixed lytic and sclerotic appearance, and some may not have a periosteal reaction at all. So biopsy is still necessary to confirm the diagnosis. MRI is the modality of choice for local extent, and usually you would have an MRI done before the biopsy just to aid in surgical planning as well. We would see low marrow signal on T1 and high on T2. Chest CT can be done to evaluate for lung metastasis, and we can see in this image that there are multiple lung metastases, and in these osteosarcoma patients, usually there would also be internal calcifications of these metastatic lesions. FDG PET CT can also be done to evaluate for metastasis, not just in the lungs, but in other parts of the body as well, and also to monitor for disease recurrence. Treatment for osteosarcoma consists of chemotherapy, both neoadjuvant and adjuvant chemotherapy is done, as well as surgery for resection of the tumor. These are notably not radiosensitive, so there is no role for radiation therapy. For the follow-up of these cases, 80% of relapses would occur only in the lung, which emphasizes the importance of lung CT in the follow-up for these patients. Next, we discuss the second most common primary malignant bone tumor in children and adolescents, which is Ewing sarcoma. This is a small round blue cell tumor that is most common in the first 3 decades of life. There is a slight male predominance as well, but it's rare in African Americans and in Asians. So this would be rarer in our population. Clinically, these also present with pain, mass, or swelling similar to osteosarcoma. But in Ewing sarcoma, we would see fever, elevated ESR, and WBC count, which would sometimes lead us to falsely think that it might be an infection. Ewing sarcoma is commonly seen at the extremities, the femur, ribs, and pelvis. On radiography, we would see a bone destruction, permeative pattern, and the lamellated periosteal reaction seen in this image, which is also called the onion skinning. There's a wide zone of transition, and we might see a soft tissue mass that doesn't undergo ossification. Here, these PA and lateral chest radiographs show an opacity in the right lower anterior hemithorax with a lobulated mass-like appearance. Axial CT was done to further assess this lesion, and we can see the axial contrast CT shows sclerosis, cortical destruction, and periosteal reaction in the anterior sixth rib. And there's an associated large soft tissue mass that's also compressing on the liver. This is a case of Ewing sarcoma. And treatment for these cases consists of surgery, chemotherapy, and unlike osteosarcoma, Ewing sarcoma is radiosensitive. Follow-up would consist of MRI and FDG PET CT. Now, osteosarcoma and Ewing sarcoma can be difficult to distinguish radiographically because they have overlapping features. This journal by Guerrera et al. Attempts to identify features that could distinguish between osteosarcoma and Ewing sarcoma. So they found that fever is more frequent in Ewing sarcoma, although it's not frequent in either disease. So the absence of fever would not necessarily make you rule out Ewing sarcoma. Volume increase is more frequent in osteosarcoma. And then these other features, fracture, pain, pain at rest, weight loss, were not significantly different and could not be used to distinguish between the two. Leukemia is not technically a bone lesion, but it is the most common malignancy in children and it can present with bone finding. Usually, this is acute lymphoblastic leukemia and would peak at 2 to 3 years of age. Lymph, pain, swelling, and tenderness can be seen, as in other bone lesions, but in leukemia, we would see features such as hepatosplenomegaly, lymphadenopathy, and fever. Most common skeletal finding in leukemia would be diffuse demineralization, and there could be pathologic fractures because of this. Half of patients will present with leukemic lines, and there can be moth-eaten lytic lesions. Here, we can appreciate on this frontal radiograph of the knee metaphyseal lucent bands, or the so-called leukemic lines. Coronal, T1, and fluid-sensitive images show the flip-flop sign. So normally marrow is comprised mostly of fat at this age, so it should be high on T1 and low on sensitive sequences. However, the flip-flop sign, there's an inversion of this normal appearance. So we can see here on the T1 image that there is a low signal, and on the fluid-sensitive image, there is increased signal. Moving on to our second topic, which is infections. We'll start with acute osteomyelitis, and this could either be hematogenous from direct inoculation from trauma or extension from adjacent soft tissue infection. But in the pediatric age group, hematogenous is the most common, and this affects the metaphysis of long bones. This is because the physiology in the pediatric patient has sluggish flow through the capillary loops and sinusoidal veins in this region, and there's poor penetration of white blood cells. This encourages bacterial seeding of the metaphysis and epiphyseal junction. Eventually, there can be pus development and further pressure, which limits the blood supply and further encourages the spread of infection. This results to infection in the subperiosteal space and abscess formation eventually. These are the more common pathogens, and note that it's also Staph aureus and beta hemolytic strep that commonly cause osteomyelitis. Radiography in osteomyelitis could show a sharply delineated lucent lesion, such as in this case, in the distal radius. You can have focal bone lysis, peripheral sclerosis, regional osteopenia, periosteal reaction, and endosteal scalloping, but usually these occur later in the course of the disease. And early on, it can be difficult to distinguish osteomyelitis on a conventional radiograph. It's normal early on in infection in the first week, and some studies say that its sensitivity is even as low as 25%. The earliest signs could be soft tissue swelling and obliteration of fat planes, as in this case. Here we can see that ultrasound shows subperiosteal fluid collection within beneath the periosteum, which is correlating with the abscess formation in this patient. And you can note that the arrow is pointing to the uplifted periosteum. So ultrasound can also be done to help assess these patients. An MRI imaging would better show the osteomyelitis. It would appear as hypointense on T1 and hyperintense on fluid-sensitive sequences. Sagittal T1, this sagittal T1 weighted image and coronal fluid-sensitive image here shows abnormally low signal intensity in the distal tibial metaphysis with adjacent soft tissue edema. And if we look at the yellow arrow, we can also see there's a small ankle joint effusion. So a contrast can be given to these patients. And in this post-contrast T1 FAT-SAT, we also see abnormal enhancement with mild synovitis in this case. This is best to distinguish intramedullary, subperiosteal, and soft tissue abscesses. On non-contrast, infection isolated to the epiphyseal cartilage may be undetectable. This is why contrast CT is best done to evaluate epiphyseal cartilage infections. Epiphyseal osteomyelitis on MRI would present as a vascular, non-enhancing regions of affected cartilage. For acute osteomyelitis, the cornerstone of treatment would be IV antibiotics. Surgical drainage can also be done to help control the source of infection. Complications would include thrombophlebitis and septic emboli commonly to the brain and to the lungs. Delayed complications include growth arrest due to bone bar formation, pathologic fracture, and chronic osteomyelitis. As we can see in this image, the infection can also spread to the surrounding soft tissues, to the periosteum, and even to the joint, leading to septic arthritis. This can also be caused by hematogenous bacterial seeding, but direct extensions of the joint space is also common, such as from soft tissue infection or osteomyelitis. This usually occurs in very young infants, and multifocal involvement is common in these patients, in young infants. So we can see here the hip is the most frequent site, and as the pus builds up in the capsule, there can be intracapsular pressure forcing subluxation of the hip joint as seen in this radiograph. Ultrasound can be done in these patients as a screening tool, and ultrasound can depict abnormal joint fluid. And MRI can be used to demonstrate concomitant osteomyelitis. But imaging alone can't reliably differentiate a reactive effusion from septic arthritis. So we could only see that there's fluid, but we don't know if it's just an effusion or it's infected. So the best thing to do would be to look at the clinical presentation of the patient. Septic arthritis patients have fever, restricted motion, or non-weight bearing. They have elevated WBC and inflammatory markers. Treatment for these patients consists of drainage and antibiotics. Of course, the best way to evaluate these patients would be to do a culture of the fluid aspirate as well. We should distinguish this from toxic synovitis, which is just a transient reactive synovitis. It's a self-limited disease and doesn't really require treatment with no long-term sequelae. It's common, particularly involving the hip also in young children, 3 to 10 years of age. So we can see in this ultrasound, we can see it can be used to confirm joint effusion and the complexity of the fluid as well as the severity of the synovial thickening. This ultrasound of the hip shows separation of the anterior and posterior layers of the joint capsule by an anechoic effusion. In contrast to septic arthritis patients, in toxic synovitis, the clinical presentation is usually non-toxic. There can be pain and there can be a limp, but usually these patients are still weight bearing. Usually these patients are febrile, and there can be normal to marginally elevated WBC and inflammatory markers. Typically, the parents would report a history of a preceding viral or bacterial upper respiratory infection or gastrointestinal infection 4 to 5 weeks prior to the onset of the symptoms. Next, we'll be going to our last topic on non-accidental trauma, and Dr. Andres will be introducing our special guest reactor.
Thank you so much, Dr. Kevin. I would like to thank first our consultants this morning who are present this morning. Of course, our TO, Dr. Kat Manlapas, Dr. Bernard Laya, our academic chairman, Dr. Brian Reyes, Dr. Maricar Reyes. Thank you so much for coming. This morning, we are very fortunate to have a very special pediatrician guest. She acceded to our request to share her expertise and her time with us. Please let me welcome Dr. Ruby Punong Bayan. She is the head of the Pediatric ER section in St. Luke's, Quezon City. Doctora, thank you so much po.
Hello, good morning everyone. Thank you for the invitation. I'm happy to be here.
Maraming salamat po, Doktora. Okay, we shall allow Dr. Kevin Yu to continue with his report, and after that, there will be a short question and answer po with Dr. Punong Bayan. Again, Doktora, thank you so much. We shall proceed po.
Okay.
Thank you, Doc. So for non-accidental trauma, almost 1 million children are harmed or endangered annually in the United States. There are 1,200 fatalities each year, and majority are less than 5 years old. This is according to Brandt. And here we can see local statistics from UNICEF in 2015 showing that 2 in 3 Filipino children experienced physical violence. This highlights the magnitude of the problem both locally and internationally. Risk factors for non accidental trauma include multiple births, boys, stepchildren, prematurity, physical disability, low birth weight, and low socioeconomic status. Clinical presentation of these patients are often non-specific, and skeletal injuries will usually be seen, but these are rarely life-threatening. Most common abuse-related injuries, aside from pure soft tissue injuries, would be skeletal injuries. So this is important to identify because although the patient will not die from these injuries, identifying it early on can help us save these patients from abuse. The patterns of injury would depend on the mechanism of injury. In infants, usually we'll see skull fractures, rib fractures, and displaced metaphyseal injuries, while in those older than 1 year old, long bone injuries become more common. These are the patterns that have a high specificity, and classic metaphyseal lesions would actually be the most specific. And then other specific patterns would include rib fractures, especially in the posterior ribs, scapular fractures, spinous process fractures, and sternal fractures. Those with low specificity would include subperiosteal new bone formation, clavicular fractures, long bone shaft fractures, and linear skull fractures. Multiple fractures seen in varied stages of healing, as well as an inconsistent history reported by the parent, would also lead to high suspicion for child abuse. And in order to identify these, we have to have a good knowledge on the mechanism of injury as well as the timeline of healing in these patients. So in classic metaphyseal lesions, these are also called corner fractures, which we see on frontal projection. And if the projection is angulated, they would appear as bucket handle fractures. In these cases, usually there's associated soft tissue swelling, but bruising is often absent. Usually, this can be seen in patients that are less than 2 years old, and this correlates with the mechanism of injury in these patients. So this usually occurs because of violent shaking of the infant, and we can see that the shearing forces cause a fracture of the metaphysis that is perpendicular to the long axis of the bone. So this requires that the child is young enough to be shaken and also that the child doesn't have the ability to protect their extremities. So usually you'd see it in less than 2-year-old patients. Here we see a 2-month-old male presenting with fever and a femoral midshaft fracture. So because of that, they did a skeletal survey, and then we saw this fracture, this bucket handle fracture. So we can see that this radiograph is slightly oblique so that we can see the peripheral margins of the fracture, leading to a bucket handle appearance. In this diagram on the left, you can see that true AP view showing the corner fracture appearance. Classic metaphyseal lesions may heal without callus or subperiosteal new bone formation. Fracture lines become indistinct so that after 4 weeks, these fractures can become inconspicuous with minimal sequelae. That's why it's important that the follow-up survey is done at around 2 weeks so that we don't miss these fractures. Rib fractures are commonly seen in infants. They may be multiple and bilateral, and you can see the hand position as the infant is shaken. You squeeze, the chest is squeezed, and usually the force is more in the posterior and axillary portions of the rib, and this is where we'd expect to see the fractures in these cases. Rib fractures heal with sclerosis and callus formation, and we can see that here there are multiple rib fractures, and there's abundant callus formation, making these rib fractures more conspicuous. But in the image on the right, we can see that there is an acute rib fracture with a thin lucent line, and this can make it easier to miss. So this emphasizes the importance of follow-up skeletal survey to see the callus formation and better identify these rib fractures. Diaphyseal fractures can also be seen in abused patients, and this would be common in the long bones, the femur, humerus, and tibia. This is usually resulting from direct trauma to the bone, resulting in a usually transverse fracture. This can be accidental, like in sports injuries, but in young children, we don't expect them typically to have these kinds of fractures and may be suspicious for abuse. Spiral leg fractures in non-ambulating patients are also suspicious for abuse because spiral leg fractures occur due to torsional forces that occur, such as when one end of the leg is planted firmly on the ground and the other end is twisted. And you don't expect these kinds of injuries in patients that are non-ambulatory. Vertebral fractures, although rare in child abuse, can also occur, and usually these would be compression fractures from hyperextension and hyperflexion during shaking, followed by direct impact. Usually, these are at the thoracolumbar junction and lumbar spine, and in these cases, paraspinal ligamentous injury or spinal cord injury may be involved, and you should do MR imaging to evaluate for these potential soft tissue injuries. There's no specific patterns for abuse in skull fractures, but these patterns are more suspicious for abuse. Bilateral fractures, fracture diastasis, fractures that cross sutures, and stellate and depressed skull fractures point more towards abuse. And we can see here in this case a comminuted fracture with abundant overlying scalp hematoma as well. And in the lower image, you can see a ping pong ball fracture in the skull of a young infant, which resembles a depressed ping pong ball. We can see an accidental trauma. Usually they hit the front, more frontal regions, so occipital fractures are more suspicious for abuse. Skull fractures are similar to classic metaphyseal lesions. They don't heal with periosteal or callus formation. And then the scalp hematoma also disappears within 3 to 4 days. So if we see these patients later after they sustain the fracture, we may miss the fracture on radiographs. Absence of fractures is also not predictive of intracranial injury, since you could have coup or contra-coup injuries without actual skull fracture. So the absence of skull fracture should not uh, cause us to rule out brain parenchymal injuries. So cross-sectional brain imaging can still be done for those patients. Not all multiple fractures would be abused. Some would be metabolic bone disease, cafe disease, osteogenesis imperfecta, rickets, or bone fragility secondary to prematurity. Basically, all of these disease conditions cause the bone to be weakened and more susceptible to fracture. For these patients, radiologic workup would include a skeletal survey as well as brain imaging if indicated. So the ACR practice guidelines, these can be accessed on the ACR website. And I just like to emphasize that skeletal survey is indicated if there is suspected physical abuse in infants and young children. So thank you for listening. Now, Dr. Punong Bayan will be sharing with us some of her expertise in handling these cases, and in particular, our protocol in St. Luke's in cases of high suspicion for child abuse, and the role of the radiologist and clinician in these cases.
Okay.
Uh,
Once again, a pleasant morning to everyone. Thank you for inviting me here. And congratulations, Dr. Kevin. That was an all encompassing, all inclusive presentation on your part. With regards to child abuse or suspected cases of child abuse, we are actually following the guidelines set by basically RA 7610. That's our Republic Act, Special Protection for Children Against Abuse, Discrimination, and Exploitation. And then, of course, through the initial efforts of Child Protection Unit Network in UPPGH. Okay, so first in the ER, when we do encounter cases like this or suspected cases like this, first is we determine the onset. We separate the acute cases from chronic. So basically, just by your history taking, we determine whether the history or the abuse happened within 72 hours. That's our cutoff for it to be defined as acute. And this would definitely cover sexual abuse cases, physical abuse cases. Okay. Of course, we know that for sexual abuse cases, we need to do forensic collection of evidence for it to be processed within 72 hours. Okay, so that's basically the reason behind it. Now, most, or I would say majority of our cases here in the country would come to us, okay, children and parents would come to us more than 72 hours. So it's more of the chronic cases or the non-acute cases, especially so again for sexual abuse cases wherein the child victim is now into the what we call child abuse accommodation syndrome. Remember, when the alleged perpetrator has has been victimizing the child, initially they would get the trust of the child. And perpetrators usually are family members, someone known to them. Contrary to perceptions of non-medical people, the perpetrators of physical abuse and sexual abuse are actually trusted caregivers and family members of these children. So when they do come in, we try to correlate the history by the child, if the child is verbal, with the physical exam findings. Okay, so for physical abuse in itself, um, we also have this documentation record in the ER. Of course, especially so for, again, for the acute cases, we need to document everything, take photographs of hematomas, maybe lacerations, and all other physical signs of external injury. And as a general rule, there is an increased incidence of what we call the shaken baby syndrome in the first 2 years of life. So the risk factors for victimization for both physical and sexual abuse would be babies who have parents who had personal histories of trauma themselves when they were kids, babies or children whose parents have alcohol and drug dependence issues, those who are unemployed, those who have financial problems, those who have been struggling with mental health issues as well, and those, of course, there is also increased incidence in areas where there is increased armed conflict, like in our countrymen in the southern part of the Philippines. So these are, and those also children who are living in orphanages, okay, maybe stepchildren, as what Dr. Kevin mentioned also. So these are the risk factors that we try to identify during history taking for us to have a higher index of suspicion whether indeed there was abuse in the situation. Okay, so again, what we do is photograph everything. I'm now talking about physical abuse, the first 2 years of life. We photograph everything. There's the computer, of course. Our system has the well-soft system software wherein we could easily put in there our findings, and then we collaborate with you, with our colleagues in radiology, especially so when we are highly entertaining possible abuse. We would collaborate with you, we would call on you, and then share, what you find, your findings, okay, your readings and interpretations of the images that we requested. We also include cranial imaging, especially so for, again, for physical abuse cases. Whenever they, especially children, less than the first 2 years of life, whenever they have decrease in sensorium or change in the level of activity, and then again, when we are able to highlight or identify risk factors for possible victimization, we correlate again. And then when we do, we also include, by the way, this is very important part of the history taking and physical examination in the ER setting. We do fundoscopy. A simple fundoscopy would definitely reveal retinal hemorrhages, which is one of the highlight findings in possible abuse, especially with your shaken baby syndrome. Okay, so as we collaborate with you, we now would do a report based on RA 7610. The physician, usually it's us, no, yung mga primary care physicians who initially investigated or took care of the child. We are obliged by law to make a report. It's a narrative report that we do, especially for acute cases. Kahit naman non-acute, no, but especially so for acute cases, we make a narrative report, a quick history there, a brief, concise history of the situation, and then our pertinent PE findings, and then the impression. Aside from, of course, filing it in our software programs, we should be submitting a case report to DSWD. So aside from radiology, pediatrics, we also call in to step in, no, the our certified social workers, because they are also bound by law to also work with us in cases of child abuse cases. So what is their role when we have identified a case of potentially abused child? If the alleged perpetrator is within the home, within the household, a family member, we do not send the patient back there because of the possibility of re-abuse or the patient suffering again another bout of trauma. So by law, DSWD can now come in for protective custody, and they will provide a temporary shelter for these children. Okay. If not the it's usually DSWD, the main office, okay, which is in Legarda, Sampaloc, wherein we call in, sometimes we fax or email our narrative report there. Well, fax is like a decade ago, or maybe 2 decades ago. But we email a report to them. Okay, so for usual days na hindi holidays, we would report them to our social service department, and then we follow them up na kailangan ma-file nila yon within the day. Okay? We also could submit a report and refer them to the nearest PNP station. We call in them also. Remember our, especially in NCR, there are women and children's desk in each of the PNP stations here in our locations. And then, okay, that's it. So we do report because RA 7610 also states that we are doing that in good faith. So there is supposedly immunity for the reporter. I know it is quite some physicians would find it a little, they might feel a little apprehensive or anxious about it when they do report it. But supposedly you may report it in good faith and with anonymity. You may just say, okay, or you course it through the section head or the department head, okay, so in order to facilitate the reporting. The important thing is for us to file the report because we are actually protecting the child to be re-abused again or undergo another traumatic experience. That's it.
Thank you so much, Dr. Punong Bayan. Very informative. So now we know the process on what to do when we get to have a very high suspicion of child abuse in patients who underwent skeletal survey. Of course, at the back of the minds of our ER doctors, parang paki-double check yung mga findings. Are they pathognomonic of abuse? So, Doctora, thank you so much. So, our role is to work hand in hand and to protect, of course, the end point is to protect the child.
Yes.
Doctora, thank you so much for your time. From the audience po, may I ask, uh, would you be, Doctora, willing to take questions po?
Okay, ma'am.
Uh,
Okay po, Doc.
Salamat po, Doctora.
By the way, may I add?
Opo, opo.
May I add something? So, aside from, of course, our reports being recorded in the WellSoft computer, no, sa computer system natin, we also provide a copy of our report Okay, mga medical legal cases kasi to the clinic of Dr. Rebosa, okay, our
Ating
legal
legal
officer.
officer. Opo, opo.
Especially if the parents
Mhm.
uh, would um, would initially tell you that there is an intention to file a case. So it's part of the history taking wherein we would ask the parents, are you decided? Have you decided to file a case against this person? Okay. But sadly, especially in the rural areas, okay, in the urban communities, sadly, wherein the perpetrators are the uncles, the
Mhm.
godfathers, the neighbors, the father. Okay. By the way, the most common perpetrator is the uncle. Okay,
Okay.
for sexual and physical abuse, just by incidents, no. But anyway, if a particular family member is the one who is the alleged perpetrator, um sadly, most of these cases do not get filed, no? They do not pursue the case. The other family members do not pursue the case. So that's the sad reality here. But of course, we are still obliged to make the report, and nasa kanila na yun, no? They would be, doing a family case conference. That's why the social worker is also very important here, the role of the social worker. Kasi eventually, the dedicated social worker for these cases is supposed to do home visitation. They examine further the family dynamics, the structure in the family, identifying again risk factors. And yun, sila na yung nagfa-follow up eventually with these cases.
Doctora, very complicated process. But
Yes, it is.
of course, Doctora, we only aim for the good of the child, and we should be very sharp in identifying these cases. So for our residents, kindly take note of the pathognomonic findings and the things that we need to request and do for imaging in highly suspected child abuse cases. Uh, if there are no questions from our audience, thank you so much, Doctora. This has been a very, very fruitful learning activity this morning for all of us. Thank you so much for your time po.
You're
Kevin,
welcome. And I thank you also again. Thank you. Stay safe, everyone. Dr. Kevin, congratulations.
Thank
yes,
you, Doc.
thank you.
Thank you sa inyo.
Thank you po, Doctora.
I'll
See
be
you.
the vaccinator today.
Yes,
Wait
Doctora.
for the tent. Oo.
Opo.
I'll go to the tent now
Oh,
here in
salamat
Quezon
po,
City.
Doctora.
Bye.
Bye po.
Thank
Bye,
you.
Doc.
Thank you again, everyone. So this morning we had a very fruitful discussion. Thank you, Dr. Kevin Yu. You did very well in this morning's grant hour. Everyone, thank you for staying till the end of the presentation. Have a good day. Thank you, Kevin.
Thank you, Doc.
Okay, turn off ko na.